Welcome to AETCM, the emergency medicine channel. Today, let us discuss about one important rheumatological disease, that is gout. Gout is the accumulation of uric acid mainly in joints. It can also involve kidneys and other internal organs, but the major clinical finding will be joint involvement. That would typically first metatarsal phalangeal joint. It's a monoarticular arthritis. Gout. So, if you know the purine metabolism, you might have learned in your physiology classes, uric acid is produced by the purine metabolism. Uric acid is produced by the purine rich, when we take purine rich food, it produces uric acid. Normally we take high amount of proteins, beverages, all this contains uric acid, or all this food material can produce uric acid. But normally when our metabolism is normal, if the metabolic cycle for uric acid is purine metabolism is normal, it will go out through our body externally, so that it will not accumulate in our body. But if there is a problem in this metabolic cycle, we are not going to the details of physiology. If there is a problem in the metabolic cycle, that can accumulate uric acid in our body. So normally it is excreted through kidney or intestinal tract, but if it is not excreted out, then it can be accumulated in our body. Then it can produce hyperuricemia, and hyperuricemia sometimes can produce gouty arthritis. The normal serum uric acid in our body will be somewhere around 6.8 or 7 milligram per deciliter. There may be slight deviation from this standard levels depending on the values in the lab. And gout is a disorder caused by hyperuricemia. It is due to precipitation of monosodium urate crystals in and around joints. So it can infiltrate into the joint and it can be around the joint spaces. Both are possible. So it produces chronic arthritis. Chronically, a patient can have first metatarsophalangeal joint involvement. So mild pain will be there. Suddenly it can accumulate. That is an acute exacerbation. So that is very important. Many patients who is having hyperuricemia, when we are doing a health checkup, we can see many patients actually have hyperuricemia. When this hyperuricemia is there, many of them are asymptomatic, some are symptomatic. So asymptomatic numbers are more than symptomatic patients. That is very important. So they may not have any features. So they may not have joint pain, they may not have uric acid induced kidney disorder, but uric acid levels are high. So many patients can have acute and chronic arthritis, like somebody is having chronic gouty arthritis can have acute inflammation. Some can persistently have chronic arthritis, and some patients can develop nephrolithiasis, nephropathy. Different types of renal involvement can be there in many patients. Now, if you see the causes for uric acid overload in our body, there are various causes. Some are genetical causes, like deficiency of some enzymes that we are not going to discuss because then we will be wasting our time on that. And some conditions, these are not modifiable. That's why they are actually, this is present throughout their life, and we will have to continuously give treatment for them. Idiopathic, without any major cause, and most of the time this will come as idiopathic also. Hemolytic disorder is another important problem, like many patients who is having lymphoproliferative disorders, myeloproliferative disorder, leukemia, bone marrow overproduction, polycythemia, all these patients can have uric acid. So whenever uric acid production is more, always ask for a complete blood count. So we'll be discussing what investigation should be done for uric acid. Many patients who is having gout, we just see the uric acid levels and treat the patient and send. But it is not like that. Whenever we have a patient who is having hyperuricemia, minimum investigation has to be done to rule out this type of conditions. Psoriasis, so skin lesions should be ruled out. Rhabdomyolysis only occurs in chronic rhabdomyolysis. Acutely, rhabdomyolysis occurs in crush injuries, long marches and all, long walking and all. You can get rhabdomyolysis. There also uric acid can be elevated. Continuous exercise, obesity, purine-rich diet. That is very important. Purine-rich diet is a high amount of red meat. Somebody is taking high amount of red meat, uric acid can be elevated. So we can advise them to reduce that red meat diet. Okay. Alcohol and beverages like colas, alcohol, all these things can also elevate uric acid. So once you know the causes, it will be easy to treat the patient. Now other conditions like very important condition is renal failure. If you see the renal failure can be produced by uric acid. If the uric acid is elevated, that can increase the damage in kidneys and produce renal failure. And renal failure itself can prevent the uric acid excretion, so that also increase the uric acid. So it is like condition where high uric acid can induce elevation in creatinine, and a patient is having renal failure can also induce high uric acid. So it's vice versa. Hypothyroidism is one important condition. So we will be doing, so once the uric acid is high, you are seeing a patient who is having hyperuricemia, you will ask for a creatinine. So already we have seen, we will ask for a CBC, then we will ask for a creatinine. Then hyperthyroidism, TSH should be asked. Okay, so I am telling the minimum investigation. Then what else? You have to rule out diabetes. HbA1c you can ask, or you can ask random blood sugar, RBS. No, chronic lead toxicity, that is very rare condition, but still you can ask for that. Toxemia of pregnancy, uric acid will be always done in pregnancy. Then Down syndrome, Batter syndrome, salicylate, diuretics. Another important cause for uric acid is diuretics. So that should be ruled out if the patient is on diuretic or not. Then anti-tubercular drugs, many of the anti-tubercular drugs also can produce high uric acid. And you can see here fatty food will be there, obesity, fatty food can be there. So always ask for a lipid profile, lipids. So basically when somebody is having high uric acid, you have to rule out some conditions, because we have some modifiable factors here. You ask for a CBC, see whether patient is having myeloproliferative disorder. In obese patients or any other patient, you ask for a lipid, cholesterol level, because that also increases uric acid. Then see whether the patient is taking a lot of red meat and reduce that red meat, and alcohol, reduce alcohol, beverages. Then see whether the patient is having renal disorder, the hypothyroidism and diabetes, and see that patient is not on these drugs. So basically we have to do investigation like that. Now when we talk about the arthritis, there are two different types of arthritis. One is chronic gouty arthritis, another one is acute on chronic gouty arthritis. Classically, first metatarsophalangeal joint in the lower limb, first metatarsophalangeal joint, that is a classical involvement. So that is called as podagra. So podagra is the classical involvement of joint disorder, a classical involvement of joint seen in gout, that is first metatarsophalangeal joint. It is podagra, and other joints are tarsal joints, ankle, knee. All these things are very commonly involved. So it's a mainly lower limb joint. So lower limb is commonly involved, and first metatarsophalangeal joint is a classical involvement. It's a single joint disorder. Most of the time it's only single joint, monoarticular involvement is classical. Now Acute problem other than this, the patient can have finger joints are involved sometimes. Pain occurs suddenly, mainly in night time when redness, swelling, local rise of temperature, all these things can occur, and it is sometimes misdiagnosed as cellulitis also. Remember, this can be aggravated by binge alcohol. Then it can be increased by walking, prolonged walking. So these are two important conditions, or missing of anti-gout tablet. So in a patient who is having chronic gout, missing of tablets can produce gout. So acute arthritis lasts for 3 to 10 days, then slowly it subsides, but the pain will be intense, severe pain will be there. Then after many acute monoarticular, oligoarticular attacks, some develop chronic non-symmetrical synovitis. They can also have synovial involvement also. So these patients can also have family history, because we have seen that it is genetically modified disease. So family history is very, very important. So we have to ask the family history. We will have to treat the relatives also. Monosodium crystals form smooth white deposit that is called as tophaceous in skin and around joints. They are seen on ear, fingers, Achilles tendon, large deposits may urate. So Achilles tendon is very important, because many patients come with severe Achilles tendinitis. So they can have severe ankle joint pain and difficulty in walking. So Achilles tendinitis is also very, very common. So you can see tophaceous here. Some tophaceous can ulcerate also. Bursitis, tendinitis, secondary osteoarthritis, destructive arthritis, pseudo-ankylosing spondylitis, carpal tunnel syndrome, spinal canal stenosis. So all these things can also be involved if you don't treat properly. Now kidneys also can be involved. Remember, these uric acid crystals, when they pass through kidneys, it can produce damage like nephrolithiasis can be there. That means uric acid stones. Urate nephropathy, it is late manifestation of severe gout, deposits of MSUM in the medullary interstitium with giant cell inflammatory reaction. Clinical features: proteinuria, hypertension, renal failure. Uric acid nephropathy, this occurs due to acute deposition of uric acid in renal tubules and collecting ducts, which causes obstruction to renal flow and acute renal failure. So kidneys also can be involved. So always check the creatinine. So creatinine should be checked. So uric acid can produce renal failure and creatinine can be increased. Anybody is having a renal disorder can also increase uric acid. So both sides it is possible. Uric acid can produce kidney disorder. Kidney disorder can produce high uric acid. So both are possible. So in a patient who is having high uric acid, severe dehydration, heavy exercise, heat, stress, blast phase of leukemia, lymphoma, all these things can produce acute renal involvement. So when we investigate patients who is having high uric acid, sometimes uric acid levels will be very high in patients with acute gout. But sometimes even it can be low also. That is very important, because all this uric acid in the blood may be deposited in the inflamed joint. So we cannot tell that only only when there is elevated uric acid you can diagnose gout. That is not correct. Even patients with normal uric acid can be clinically diagnosed as gout. So it is only seen in 12 to 43% of the patients. Then, like we discussed previously, we have to ask for CBC, lipid profile, urine routine, creatinine, TSH. So these are the minimum investigations you have to do it in a patient who is having high uric acid. Now X-rays, joint aspiration can be done. This is not routinely done in a patient who is coming to teaching area. We can do this. Otherwise, even without all these things, clinically we can make a diagnosis of gout, because many patients can have a monoarticular joint involvement. If you clinically have any doubt only, you should go for all these things. So demonstration of monosodium urate crystals can be there in microscopy, so that you can see here. This is pseudogout that we are not discussing now. So monosodium urate crystals which cause gout appear needle shaped when viewed under microscope. That is very important. Now, X-ray of joints are very important, but routine practice we don't do all these things. Clinically make a diagnosis, you can treat, but when you have doubt, always you can check it. Radiological features usually not seen until 6 to 12 years after initial attack. So that is an important feature. Nowadays we don't see this because most of these patients get treatment early itself. But if the patient is, unfortunately, if the patient has not received any treatment, he can have these changes. This present in around 50% of the patients. Punched out lytic bone lesions, sclerosed margins. That is very important sign. You can see here punched out bony lesions. Joint may be narrow. Punched out lesion is here. Soft tissue swelling is a classical feature. So that also we have seen. The management hyperuricemia who is asymptomatic or there is no renal calculi, there is no elevated creatinine, no need to treat. So if the FLP is high, fasting lipid profile is high, you may have to go for diet restriction, diet and statins. If TSH is high, then thyroid drugs. If creatinine is high, treat the cause for renal failure. But if there is a problem like end organ damage like creatinine high, if you are not able to find out any reason for elevated creatinine, then uric acid may be the reason for elevated creatinine. Then purine rich diet that should be avoided. Red meat is the most important thing, and seafood. Other things are like beverages, alcohol, so many other things like bakery items. All these things we have to avoid. Diuretics and pyrazinamide can produce high uric acid, but when we discuss about uric acid induced problem, we advise to avoid drugs, avoid this type of drugs. But if the drug is started for some important purpose, like a patient is having tuberculosis, and we are treating with pyrazinamide, even if the uric acid is high, just continue the drug because this type of uric acid normally will not produce any problem. Diuretics, if it is started for cardiac failure, then you can continue the diuretics. But if the uric acid is producing some problem like acute gout, and on top of that you are using these drugs, then better to give some drugs which can control the uric acid. Avoid alcohol, bakery items, beverages, drinks, all these things are important. Now, in acute attack, like any other arthritis, you can go for NSAIDs. You can go for naproxen, indomethacin, diclofenac, whatever it is. And remember, in acute attacks, you have to give a drug like colchicine. Colchicine is a very important drug. It is given in a dose of 1 milligram initially, and 0.6 milligram is given in textbooks, but available tablets in India is 0.5 milligram hourly till the patient develops vomiting or diarrhea. Or you can give 0.5 milligram every 4th hourly and maintain the dose of 3 milligram per day maximum. So 3 months you can continue these drugs, or till the patient develops symptomatic relief you can continue the drugs and monitor blood counts and LFT. Then if the patient is having severe pain, you can go for steroids. Patient is not able to maintain on NSAIDs, go for steroids. Even intra-articular steroids also will be useful in that condition. Sodium bicarbonate is an alkylating agent. Many doctors, they don't prefer this because many of these patients can have associated condition like this. So better to avoid. Or in a patient who is stable, you can use it. Rasburicase is a drug which is used in tumor lysis syndrome. Tumor lysis syndrome also you can have hyperuricemia induced problem, but there you can use rasburicase, not in routine cases. 0.2 milligram per kg once daily for up to 5 days you can give. So rasburicase is reserved for tumor lysis syndrome. Now allopurinol, once it was a major drug given to reduce the uric acid. It's a preventive drug, it's not an acute drug. Should never try allopurinol or febuxostat in acute attacks because acute attacks they may not work. It will only slowly reduce the uric acid. This drug prevents the conversion of hypoxanthine and xanthine to uric acid. They reduce the production of uric acid. Dose is around 300 milligram single dose. Slowly increase depending on the serum uric acid level up to 2 gram per day. Maintain serum uric acid less than 5. Instead of that, nowadays we are using febuxostat. It's a safe drug. This has got some adverse effect. It can produce allergic reaction in many patients. So allopurinol, nowadays the usage has come down, but still many patients are on allopurinol. Newer drug is febuxostat. It's an inhibitor of xanthine oxidase, 40 to 80 milligram once daily. No adjustment necessary in patients who is having renal or hepatic disorder. That is an advantage. So there are two advantages. This can produce some skin reaction in some patients, and it should be avoided in elevated creatinine patient who is having elevated creatinine or LFT altered patients. You can avoid this. Instead of that, you can go for febuxostat. Interleukin 1 blockers are available nowadays. Canakinumab, that is a drug. That's an interleukin 1 beta inhibitor, monoclonal antibody. Subcutaneous, you can give 150 milligram as a single dose can be given. So that is a newer drug available. It's costly. So whenever we give drugs like febuxostat or allopurinol, we have to advise the patient to take a lot of water. Otherwise, what happens is we are giving all these drugs, and you can think that uric acid is reduced, but initial phases there are a lot of uric acid go through the kidney. Okay, if you don't give adequate water. So if the water is not given, all these uric acid crystals will block there in the kidney, produce block or crystals will form stones there. So to avoid that, you have to give plenty of water. Whether you are treating the patient with drugs or not, you have to give plenty of water to prevent the renal involvement by the uric acid. High purine diet should be avoided, especially red meat. That is very important. Red meat should be avoided. Yeast and yeast extract, that is mainly used in bakery items. Beer is one important beverage that should be avoided. Then lot of vegetables also should be avoided. So all these things you can read here. So that should be avoided to prevent further attacks. So we have discussed about hyperuricemia or gout. Hyperuricemia doesn't mean that patient is having gout. Hyperuricemia is only increased uric acid due to various causes. Gout is an arthritis, gouty arthritis. In that patient, he can also have gout induced or uric acid induced nephropathy or renal stones like that also. Remember one thing, there are some diseases associated with uric acid, high uric acid in blood, especially hemoproliferative disorder. So we have to do a CBC. Patient can have high lipid profile. Some patients can have high lipid profile. Treat that. Patient can have elevated TSH, hypothyroidism. You have to treat it. Patient food habits must be changed. The patient is taking a lot of red meat. That itself can produce hyperuricemia and gout. So that should be controlled. So it should be a multi-dimensional approach, and always remember creatinine. Don't forget to check the creatinine, because creatinine can produce increase in uric acid, and uric acid can produce renal failure. Both are possible. So we have to be very careful. So that is about gout. Thank you.